I wish we could turn the camera around. So we've got about 200 pediatricians from DC, Maryland, and Virginia, all gathered here talking about obesity care from a clinical perspective. And as we've chatted, we felt it would be useful for pediatricians who are, again, poised on the edge of the pool and actually being invited to sort of jump in and take on more direct care and counseling as it relates to obesity screening and management, that we would spend at least a couple minutes now, rather than wait until our December Business of Pediatrics meeting, to sort of touch base with our pediatricians around coding guidance and recommendations as it relates to obesity care in the primary care practice setting. So with that, we are going to actually turn the presentation over to Jan Blanchard. Jan is a licensed coding guru. I don't know what the title is. I think that's the official title, right? It's like
it's the most often used.
Who works with Chip Hart and the PCC folks and other folks up in Vermont, and actually has presented to some of your office managers earlier today, and today we're sort of huddling up now with direct care providers, pediatricians and nurse practitioners and others who are seeing kids with obesity in primary care practice. So with that, I'm actually going to transition it over to you, Jan Blanchard. Take it away.
Great. Thank you so much, Dr. Weissman.
So I just want to make sure, looks like we got the screen going. Great.
Is that doing it? Excellent. Yeah, it remembered my settings from this morning. I love when that happens. Thank you for that introduction. And as we have very, very little time today to go over what can be a pretty dense topic, I'm going to jump right into this. The content that I presented this morning was a billing and coding lens on the updates to the clinical guidelines. So there'll be sort of a similar approach this afternoon, but the request was that we go through some vignettes that would put this into an encounter by encounter type context for you. So with that, I want to share just a disclaimer. Use your best judgment and your common sense with the things that are shared today. I do my best, and you shouldn't depend entirely on my advice for any of this stuff. I always start talks like this with a little bit of warning so that I set some realistic expectations about the difference between coding and billing. I am a coder, so I am skilled in applying regulatory and coding standards to your encounters, translating your documentation and your experience into the numbers and letters that we send off to payers for clinical and payment purposes. And clinical assessment, I mean the HEDIS measures, clinical improvement, that sort of thing. And the corollary to that is billing. And a lot of folks conflate those two concepts. Billing is the hoops that you jump through to get paid for the services that you've already rendered. So the folks, I'm an expert in the application and the theory. I'm an expert in the theory, and the billers in your office or in your billing service are the experts in how your payers require that you report things in order to get payment. So with that little bit of insight, I wanted to, many of these slides will just be for reference. I've got lots of slides for just 15 minutes and then about 15 minutes for Q&A. So I wanted to put all these things in one place simply for your convenience. So some of these slides are just going to be links to the guidelines themselves, which is the case here. And getting right into the vignettes, the first that I was asked to explore was, what does it look like when I send a claim off to, or I code for a well visit that includes obesity care? And that is, this is a short summary of what that code or that series of set of codes might look like. So you've got the well care that represents the periodic screenings, not the screenings, but the periodic care, your examination, your assessment of the patient, your checking in, your cognitive effort. And you've also got those age-appropriate screenings that you want to be sure that you include. So I've included a link here to the periodicity schedule that'll help you to note exactly which things, what the recommendations are for the periodicity schedule. There are some resources out there that will translate that into codes as well, which is really handy. I created one and have not yet updated it, so I would have offered my own, and I'm not up to date in 2023 with it yet. The labs, speaking from the obesity perspective, the labs that you might do or the lab coding that you might report will depend on whether you are sending the labs out or doing those labs in-house. So for labs that you're sending out, you would bill for the needle stick. I'm thinking specifically of the lipid panels or the individual dyslipidemia, triglyceride, individually performed labs. If you're sending those out, you would bill for the venipuncture, the 36415, and the 99,000, which is conveyance of that specimen to the outside lab for analysis. So that's all the paperwork that you have to do. It is intended to cover things. If you're paying, it'll contribute toward paying for courier service, that kind of thing. If you are doing the labs in-house, you would, instead of the 99,000, you're not conveying it anywhere, but you would perform the analysis itself. So if you've got a more advanced lab in your clinic, the 80061, the 82465 through 83718 through 84478, that's the general range of the dyslipidemia triglyceride components of that 80061 panel, that lipid panel. As for diagnosis coding, the series of codes for obesity themselves are E66 dot and then a suffix. There's a reference slide later in the deck with the details around those and the variety of types of obesity that can be coded, and as well as the BMI code. So earlier this morning, I went into some more detail than I will bore you with about the coding requirements around BMI coding and social determinants of health coding, which I bring into this conversation based, again, on those guidelines. There is emphasis that I saw placed in some of the guideline summaries, the change summaries, on the whole picture. So understanding the full context in which the patient is experiencing obesity. And so that's things like their socioeconomic status, the family structure that they live in, their first language, any cultural differences in attitudes toward food and diet, those sort of things. Those all have, and you have an opportunity to express all of those in the Z55 through Z65 ICD codes. Now, I know some of the impetus for this particular vignette being added for exploration is that combining a well visit with an E&M where you manage obesity was really the crux of this question. So I wanted to put the sick services, the sick considerations on a separate slide so that we can do it proper justice. And it is really a very simple coding question as to when you submit a -25 modified well visit with, a -25 modified sick visit with well care, concurrent with well care. And it breaks down to, if you managed the obesity that day, it is appropriate for you to be paid for that management. Now, the nuance comes when you think about, that phrase, the -25 descriptor includes a separately identifiable, distinct, you hear descriptions of that modifier are only applied when there's a significant additional effort to manage the problem. And my judgment call on that, my interpretation of that is that if you had to take yourself out of your well care brain to focus on that obesity problem, and you had to assess it anew, either because it's a new problem to you or because there is exacerbation, there's progression, there's side effects of any previous treatment. If you have to take off your well visit hat, your preventive care hat, and put on your diagnostician hat in order to do justice to that service and to properly treat that patient and to manage their obesity that day, then that is your starting point for building an E&M that you would accompany with that well care when you send that claim. The things about the guidelines that I think contribute to and create documentation opportunities to support sending an additional E&M are the acknowledgement in the guidelines that this is a chronic illness. This is something that I'm keeping in my back pocket for when I appeal a claim, because the definition of chronic illness, or the that it is understood to be by your specialty society as a chronic illness, is more evidence that you can submit in support of payers paying separately. So there's the documentation goals that you have for capturing the encounter, there's getting the codes out the door, and then there's that final step of making sure the payers pay it and don't take the money back. So this is one of those things that supports that. This is, again, a feather, an arrow in my quiver. That's something that I'm going to hold on to and use in my appeal letters. It is understood to be a chronic illness. You can't tell me that that doesn't contribute to the number and complexity of problems in that medical decision-making assessment that you have to make with leveling every E&M, every sick E&M. Caregiver history is acknowledged as being part of the social and contextual interview, and the importance of that data that is recommended that you assess. That's more data and more information that you have to factor into your thinking. Again, supportive of somewhat higher complexity care. The labs you ordered, the labs that you reviewed for obesity in particular in this example, those contribute to the data that you have to take in, the information that you have to synthesize with everything else that the family and the patient are telling you. You're pulling that whole picture together. Now the labs ordered in the review and reviewed specifically for obesity would factor into that complexity as well. And again, like every other sick visit, the risk of treatment or diagnostics would factor into that. It is a factor. So anything that is more evidence of management, that is more work that you're doing to treat the patient for that problem that day. So it's not part of the well care. You are treating a problem. This is problem-oriented care. The other option, I'd be remiss if I didn't mention, is the time that you spend on managing the obesity that day. So if that is significant, again, if you had to manage any community services, any services outside your office that are assistive or supportive to the patient in addressing obesity and recovering, any work that you do to talk with other specialists, any records that you reach out to another practice or another caregiver for, all of that time that is spent. And midnight to midnight, you'll see that parenthetical there, is the rule when you use time to level care, sick care. You can count everything that you did for that patient on the calendar date on which the face-to-face service happened. So if you spent a bunch of time reviewing a long dietitian's summary before you even saw the patient, either for the first time or if that was an interval history, if you had a lot of work to do for that, yeah, I would err on the side of calling that significant separately identifiable sick care in addition to the well care that day. Another vignette for purposes of exploration is, what about a well visit with controlled obesity? And that is a very similar answer to the previous answer. It is if there's no management, there's no E&M. So if the patient is not experiencing anything that requires any intervention, if it's you checking in with them to say, is what we're doing working? Are you progressing? Are you happy with your progress? Checking in about a plan of care that's already in place without any changes, without any adaptations or concerns raised, any side effects, then that in my mind is not management of that problem that day. In addition, not significantly so, in addition to the E&M to report it separately. So similar codes, just no E&M for that day. Another weight management follow-up, and this being for a provider. So when I say in this context, I assumed that the question named provider as an MD or a qualified healthcare professional. The recommendation in there is a resource that was published by the AAP that includes some operational hints, tips, and tricks that I link to, if not in the talk from earlier today. I will find it for sure to be certain. That classifies either that you're performing E&M services or something called IHBLT. I'll define that on the next slide. And again, the labs that you might do for that a clinician would order for management of obesity won't change much in this weight management. It's sort of monitoring, you're checking in as they go. You might repeat those labs, you might not, depending on the interval. You may also be using assessment tools. So if these are peer-reviewed, standardized, scorable assessment tools, something like the Brenner Fit, I couldn't include that here. It's a copyrighted tool, but you might bill a 96160 if the tools that you're using for these assessments, these interval assessments, match that standardized, scorable, interpretable 96160 reportable. And again, those obesity, BMI, and social determinants of health ICDs would apply as well. So IHBLT, I'm telling you, and I can't see your faces to know if you're rolling your eyes and if this is old hat to you, but this intensive health, behavior, and lifestyle treatment type of service is mentioned, as I said, there it is. Yeah, the link on this slide is to the Obesity Treatment and Approach in the Primary Care Office resource published by the AAP. Notes that when the clinician, when the MD or qualified healthcare provider is rendering this service, that E&M services, time-based E&M services are appropriate for reporting them. The way that they define that type of service, that IHBLT, is that it is face-to-face, it is family-based, multidisciplinary counseling on nutrition and physical activity. So they go on to say that preferably there's a resource based in your community that you can refer them to, and that's what this, what the final bullet point on this slide refers to. If it's external, if it is community-based and not being rendered by your clinic, that's another variation on this. But they go on to say, you know, what the duration of this type of service, where the success is typically found for in duration of this type of service, that should involve at least 26 hours over at least 3 to 12 months. And if clinicians themselves are performing those, they I note here on this slide is the initial treatment would be expected to be around 45 to 60 minutes. So those codes would easily be a 4 or 5 level for a new patient, and certainly a 5 level for an established patient based on time. Should be scheduled within 1 month of a well visit, where you're either identifying or doing interval check-in for obesity, and then ongoing treatment. Again, if rendered by the managing clinician, would be at least a 20 to 25 minute visit at least monthly. So those are opportunities for the type of counseling for receiving payment for the services that go into this change in guidelines. Again, just to be complete on this, in this idea, the IHBLT, when it's external and E&M by the managing clinician every 3 months or at the midway point is recommended as well. So that would be another E&M that you could bill either on medical decision-making or by time. So this third weight management and follow-up, not by a clinician, by the managing clinician, but by a dietitian, has some caveats in it. The services that might be rendered in office by a dietitian can fall into family-based care, family meeting with the family, the counseling, intervention. These are all of this whole series of codes here are time-based, and these are not to be billed by an MD or a qualified healthcare provider. These are strictly for clinical staff, qualified clinical staff. And the variations across these codes are, I think I started to say, whether it's individual or group, whether it's the patient alone, the patient with the family, or the family without the patient. There's that variation in there as well. And these are for interviews, observations, and assessments. So you can see that description in the quoted from CPT is that these are assessments and interventions to improve the patient's health and well-being, utilizing psychosocial and/or psychosocial intervention, psychological or psychosocial interventions. It's late in the day and I am tongue-tied, designed to ameliorate specific disease-related problems. So that is an opportunity for billing clinical staff, qualified clinical staff services. These are codes you would want to investigate and compare to the services that you either have in mind or that you're already rendering. This fourth vignette, I feel like I'm going at the speed of light. It was asked that if obesity accompanied by one of the likely additional problems associated with obesity was also treated, what would that look like? So obesity plus headaches, or obesity plus PCOS, or obesity plus hip pain. I read between the lines in that question. The number one question that I get asked is this a level 4? And as I sat with this question, that is definitely the flavor that I took from this, is that's where that judgment call is, that the level 2 visits, are super simple. They're no-brainers. You're kind of gauging progress. You're keeping there's not a lot of challenge in those, either cognitively or hopefully for the patient. They're relatively well. And the level 5 visits are easy because those are the ones you're thinking, maybe I'm going to send this kid to the ER kind of problems, where the 3 and 4 is where that judgment call happens. So the question I get most often is this a 4? And that's what I read into this. And the question, unfortunately, is maybe, because with each of those problems, it comes a clinical determination that you have to make related to the nature of the problem. So the things where your judgment calls lie, of the 3 medical decision-making elements, the type of problem, the data that you reviewed, the data and information you reviewed, and the risk to the patient of any labs, diagnostics, or treatment. Of those 3, the judgment call is in how you characterize the problem. So again, the bullet points that I have in here are the level 4 descriptors for bullet points. And if that headache is a chronic headache, if that's something that this patient has been seen for before, and you're managing it alongside the obesity, 2 or more stable chronic illnesses for sure would be a level 4 problem, a level 4 set of problems for that encounter. If it is not, if it is a new problem and you're concerned enough about that headache that you really don't know where this is going to go, and in your clinical judgment, you would characterize that as a new problem with uncertain prognosis, the headache on its own could be a level 4. In fact, it might even be higher than that, because if you had one or more, the level 5 is one or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. So if you've got that in play, you might actually be looking at a level 5 problem. So there is not a way to characterize, and I'm asked to do it often, and I disappoint folks on a very regular basis when I can't say, conjunctivitis is a 3, and strep throat with a lab test with a rapid strep and a culture is a 4. It simply isn't that easy. It is very much dependent on the way the patient presents, the choices the clinician makes for assessment and treatment, and for data gathering, whatever data and consulting and conversation and information review happen that day, and or the risk to the patient of the choices that are made that day. That is really what it comes down to. It is impossible to even look at a combination of problems and say how you could code it. So I fear I have disappointed yet another room full of folks. The remainder of these slides are for reference. So at this point, I would love to open this up for questions. This is a tool that's included. The image itself is a link to this tool where you can download it. You are welcome to use it for review, for audit, and it contains the 2023 changes. It includes the 2023 changes to the E&M. There are just little tweaks that were made in the examples that are offered at each of the visit levels for the 3 elements, as well as a concise summary of the time ranges for level 2 through 5 when billing based on time.
Thank you, Jan. And you can't see us, but I think a lot of people are engaged, not necessarily disappointed.
You're very kind.
We have about 5, maybe max 10 minutes for questions, but are there any in the audience currently? Hold on, Jan, we're just getting the microphone to people.
Yeah.
Hi, I was wondering how you would code if you wanted to have some sort of class where you're maybe going over nutrition, but you're the person teaching it, but it's multiple families at a class. Is there a
that
way
is a
to
great
bill
question.
for that?
There absolutely is. And if you don't mind me, if I could stop sharing, I know I've got that in the slide deck from this morning. There are definitely, I can give you chapter and verse, or I can refer you to the slides from this morning, whichever is more expedient. I don't know if there are other questions.
That's great. There are a few, so we'll definitely share those slides with everyone.
Okay, awesome.
Go ahead, Dr. Hop.
The question I have is not, this is billing really, so you can either answer or maybe defer, maybe one of the other doctors, that Dr. Tucker or one of the others may answer. But the question I have is really about getting things covered under the diagnosis code of obesity. And I still get, it seems like that gets kicked out. And I don't know if it's still true, but it seems like I remember just in the last year having a family that 2 different kids, 2 different providers saw them. One sent all these labs, you know, for the same risk factors, but one only put the diagnosis code as well child care, sent all these things out, which is not really well child care to do all that, but it was done. And it all got covered and paid. And the other one put it under obesity and it was all kicked back and parent had to pay for it and they were very upset. And then what could we do after that? And I'm also with these follow-up visits, if you have obesity as the primary code, I still keep hearing that it's not covered. You have to have hypertension or you have to have something else. And is that true? I'm curious if, am I still living a few years back, or is that still true, or is that variable? I mean, it feels true to me still, so.
Yeah, maybe a show of hands. It sounds like I see some nods. This is a show of hands, I'm sorry, if you too are having difficulties getting ICD-10 codes for obesity
Covered and paid.
Covered and paid. And it looks like at least half the people are waving their hands.
Oof.
Jan,
Yeah.
tell us why your face just did that.
Well, it's shocking to me. I just never lose my childlike innocence when it comes to payers, I guess. The idea that they are, I heard the laughter and I deserve every joke, every chuckle. That they are, I have a million questions, and the prominent one is, what reason are they giving? If they're carving it out, if they're saying that it's not covered, that sounds to me like a feature of the policy that the patient is covered by. If they're carving out entire realities from your patient's lives and deeming them non-covered, it is a function of the poor coverage. And I don't see any clinical reason for it, and I don't see a coding shortfall without knowing more about the denial reason that they issued.
Dr. Tucker has a quick comment on this too.
Yes, you are correct. And I think this is similar to the medication issue, where I think a bigger issue with certain private payers and employer-based plans where they have a carve-out where they don't cover weight management. They will cover Ozempic if you have type 2 diabetes, but not for weight loss. And it can be the same thing with coding. It's getting better, but to be safe, we will typically try to use something else as the primary code and obesity be a secondary code. So abnormal weight gain is a favorite of mine, which I highly recommend and seems to be reimbursed more consistently. If they have any comorbidity at all, even acanthosis nigricans, put that as your primary code.
So we'll try to circulate some of those. I think part of what our pediatric health network is also trying to do, not just set up contracts with payers, but actually some payer advocacy, which is also being done at the national and state AAP chapter levels. So some of this is, we've heard this earlier today, we've heard this now. We appreciate that, what's the best word for this? It's sort of sleazy, you know, the way the payers are sort of approaching this. And 1 second, Mel. And so we have work to do. I think this will be part of our Business of Peds work. This will be part of, if we're going to do some work around, you know, supporting adoption and implementation of guidelines through some monthly echo huddles or whatever, we will sort of stay on this, because we're not going to fix it all today. I think Alicia helped in terms of identifying alternate diagnosis codes that may open the door on some of these, but even those workarounds aren't really the right way to solve this. We need to sort of get to the right space. Can I just ask Mel for a comment about some of the state work?
The issue of the coverage for the diagnosis of obesity was taken up in the Maryland General Assembly a number of years ago. And after 3 years of fighting with Care First, it is a diagnosis that is covered under state statute. They have a limitation on the number of visits that you can cover, but that's for Maryland. And that's only for those companies, it only really applies to those people who have a policy that's generated in the state that's not an ERISA policy, which, you know, major manufacturers, they write their own policy. And so the state insurance policies and regulations don't apply, but sometimes they're owed. But in any event, in Maryland, Maryland insurance should be covering obesity, period.
And my guess is it's not 26 visits a year that's covered, right?
I'm sorry?
My guess is they didn't land on 26 visits a year that are covered.
Not too close.
Yeah, slightly facetious joke. Yeah.
We're all going to work together on this, okay? But I think these are great questions. Jan's got the answer to some things, but some things actually, there's a national landscape and then there's sort of the local challenges, and we're going to have to sort of straddle both and all work together. Back to the Q&A and Jan, sorry.
Are there any other questions? Yep.
I just had a quick question. Do you include obesity and BMI that indicates obesity on the same encounter?
Yes. Yeah, that is a great question. We got more into the coding aspect of that earlier today. In fact, the BMI codes really should not be reported primary. They shouldn't be reported in isolation. They should have the corresponding condition code. So BMI is sort of like a calculation circumstance code. It's a range, it's a reporting tool as opposed to a condition. So yes, great question. The obesity and BMI should both be included when they're both present. The BMI can be added by other staff without it being documented by the clinician. The clinician has to document the condition for sure. There's no wiggle room in the clinician having to say this rises to obesity. This fits that obesity diagnosis. If it is noted somewhere or measured by clinical staff and noted in the medical record, coding staff they do have the latitude to add that to a claim if you didn't include it yourself. So don't spend a whole lot of time sending claims back and forth or encounters back and forth between you for that purpose. That's a little bit of time saving.
In a simple way, a BMI is a measurement, but if you're actually rendering care around what the BMI tells you, with a diagnosis of overweight or obesity or whatever, those are the working diagnoses for added work or care that you're doing.
Correct.
It's a challenging space, and that's why we're here today. We're trying to figure out how to navigate this in terms of clinical knowledge and actually crosswalking it into our coding and billing practices. I'm sorry, Jan.
No, I was going to add to that. Anytime you get a requirement from a payer to do something other than what is proper coding, which is to have that primary E code for obesity and have the Z code for BMI percentage be anything other than secondary or tertiary, get that in writing, because they'll turn right around in a few months and come back and start denying payment because you're doing exactly what they told you to do. So be sure that you've got something that you can hang on to, and not just, I spoke with, Denise at the 800 number on 6/21/23 kind of thing.
All right, last question.
Well, it's just a suggestion. E668 is central obesity, which when kids come into preventive cardiology for a dyslipidemia is almost always associated. I've never had pushback on that. The Endocrine Society has that covered as metabolic obesity. So it almost incorporates the comorbidity of obesity.
Yeah, another nice strategy to try.
We'll explore that.
Yeah.
All right, well, Jan, thank you so much for your time today. Enjoy your upcoming trip, which is the reason she can't be with us in person. And thank you, and for everyone, we'll be sharing her slides, because I know these can be very helpful. And if you have any further questions too, we can ask her to elaborate via email that can help get your answers.
Absolutely.
Answered.
Please do.
Questions answered. All right, great. Thank you,
Jan.
Thanks, Jan.
Thanks, Jan.
Bye.